Hello, everyone. Thank you all for joining us today. We're going to go ahead and get started, and I'm going to pass it over to Lourdes Rivera for opening remarks.
Great. Thank you so much, Lauren. And I see that people are still joining us very quickly. I am Lourdes Rivera. I use she, her, and ella pronouns. I am president of Pregnancy Justice, which defends the rights of people who are being criminalized because of their pregnancy status and advocates for pregnant people's personhood and bodily autonomy. Welcome to this webinar panel discussion with an incredible panel of speakers on the rise of pregnancy criminalization. I am so heartened by the level of interest. We have about 230 participants and counting. Pregnancy Justice conducted research to understand the scope and trend of criminalization throughout the Roe years, the 16.5 years leading up to the Dobbs decision in June 2022. And this research builds on our prior analysis covering the period of 1973 to 2005 and represents the most comprehensive baseline of pregnancy criminalization to date. And today, we will hear about the accelerating trend of pregnancy criminalization that is harming pregnant people. This trend has been driven by two factors: fetal personhood and the long wake of the war on drugs. And the first driver, fetal personhood, an ideology that deems fetuses or fertilized eggs to have the same, if not more, rights than a woman or person carrying the pregnancy, or the right to one's own health, has been gaining traction and is embedded in state laws and judicial opinions. The 1973 decision, Roe versus Wade, provided the right to an abortion, but it did not guarantee access, as many of us know, and even less so as the decision was being eroded over time. And yet it served as an important, albeit imperfect, barrier to fetal personhood. And now, with its overturning by the Dobbs decision, we must even be more concerned about the criminalization of pregnancy, with 15 states having broad fetal personhood laws that are yet to be fully realized. And the second driver is the decades-long legacy of the war on drugs. There has been a greater understanding of substance use as a mental health and a public health issue in the most recent opioid drug and methamphetamine crises. But for people who are pregnant, the same punitive approaches that targeted Black and Brown communities by the war on drugs are being wielded against pregnant people, including white pregnant people, as you'll hear later. And these drivers have opened the door for state actors to police pregnant people and criminalize any actions deemed to be harmful to a fetus. So we're going to have the opportunity to dig deeper into the findings of this research today in this hour, and to have a more robust discussion about the context and significance of these trends for pregnant people, communities of color, and people with low socioeconomic status. And with that, I will turn this over to our very able moderator, Fikayo Walter Johnson, who is a research and program associate here at Pregnancy Justice and co-author of the report. And I want to really just thank this incredible set of panelists whom Fikayo will introduce, as well as the Pregnancy Justice team, who have worked extremely hard to coordinate this webinar. Thank you.
Hi, welcome everyone. I'm so excited to be here today to moderate this important discussion. Before we begin, I'd like to briefly introduce our esteemed panelists and share key findings from our report. So for further detail on our panelists' expertise and background, please monitor the chat for their full bios. In alphabetical order, Dr. Khiara M. Bridges is a law professor and scholar at the University of California, Berkeley School of Law, specializing in race, class, reproductive rights, and the intersection of the three. She's a co-editor of a reproductive justice book series that is published under the imprint of the University of California Press, as well as the author of Reproducing Race, an Ethnography of Pregnancy as a Site of Racialization, and Race, Pregnancy, and the Opioid Epidemic, White Privilege and the Criminalization of Opioid Use During Pregnancy, which was published in the Harvard Law Review in 2020. Kassandra Frederique is the executive director of the Drug Policy Alliance, a national nonprofit that works to end the war on drugs, which has disproportionately harmed Black, Latinx, Indigenous, immigrant, and LGBTQ+ communities. DPA proposes alternatives grounded in science, compassion, health, and human rights. During her time at DPA, Kassandra has built and led innovative campaigns around policing, the overdose crisis, and marijuana legalization, each with a consistent racial justice focus. Purvaja S. Kavattur is the lead author of Pregnancy Justice's new report, The Rise of Pregnancy Criminalization. She's an accomplished health researcher that has worked alongside the United Nations, Harvard, and Columbia universities on various menstrual and maternal health research projects across Ethiopia, India, Kenya, Senegal, Tanzania, and the United States. While currently a public interest law scholar at Northeastern University School of Law, Purvaja continues to share her expertise on abortion and contraception with movement partners, amongst other reproductive justice issues. And finally, Dr. Ghazaleh Moayedi is a board-certified OBGYN educator, writer, and community activist who works at the intersections of reproductive health, rights, and justice. She's also the incoming board chair for Physicians for Reproductive Health and the founder of Pegasus Health Justice Center, a community health resource that creates holistic community wellness through justice-centered, patient-oriented healthcare and advocacy. She's also a founding member of Centering Equity, Race, and Cultural Literacy and Family Planning, CER-CLFP, a collective that works to name, disrupt, and dismantle the systems of oppression in family planning care. Thank you again to our panelists. So now I'm going to share some high-level findings, and then we're going to dive into this fantastic discussion we have prepared for you all. So our first report, titled Arrests of Forced Interventions on Pregnant Women in the United States, identified more than 400 arrests or forced medical interventions from 1973 to 2005. In our latest study, we found 1,396 criminal arrests that took place between 2006 and June 2022. So to put this into perspective, in about half the time, Pregnancy Justice found more than triple the cases. Our data included cases in which a person's actions or inaction during pregnancy was a necessary factor leading to their arrest, or to justify imposing a harsher and/or different penalty, for example, a parole revocation. So I'll note that researching criminalization cases is complex. There is no universal or systematic database for criminal cases across the country, but at the moment, this report is the most comprehensive and robust accounting of pregnancy-related criminalization in the US. Importantly, the cases show that pregnancy outcomes other than abortion, including birth and pregnancy loss, have been far more likely to result in criminalization. So 55.7% of the pregnancy criminalization cases in our report involved a live birth with no health problems reported in the data. Of course, in a post-Dobbs world, this distribution could shift. In the last 16 years, almost every state has had at least one pregnancy criminalization case, but while analyzing geographic trends, we witnessed a Southern story emerge. If we break it down by census region, 86.1% of cases originated in the South, followed by 7.1% in the Midwest, 3.8% in the West, and 2.9% in the Northeast. We can tie this geographic distribution and increase in criminalization directly to the expansion of fetal personhood ideology, which Lourdes mentioned at the beginning of our discussion. The states that contribute to 67.5% of criminalizations in the country, Alabama, South Carolina, and Oklahoma, are also the states where the highest courts recognize fetuses as people in their criminal laws. Now, to quickly touch on who is most impacted, to examine the socioeconomic breakdown of our study population, we consulted case records to see if the individual qualified for a public defender, often described as indigent defense. Although the threshold to qualify for court-appointed counsel varies by state, our data shows that over 80% of pregnant people arrested face substantial financial hardship. Given the legacy of the war on drugs, we expected our current report to involve a disproportionate number of arrests of Black pregnant people. We were correct, but the majority of arrests made were of white pregnant people. So we'll discuss this observation during the panel, but make no mistake, race and class influence trends in criminalization. And as a quick caveat, there are several ways that this report doesn't capture the full scope of who is being criminalized. We only relied on official court documents to report an individual's race, but we know that the criminal legal system fails to accurately document Hispanic, Latinx, Indigenous, API, and multiracial identities. Finally, we can share the most common grounds for arrest. 9 out of 10 cases involve allegations of drug use, and a quarter of cases involve alleged use of legal substances. So even as we as a society have developed an understanding of substance use as a mental and public health issue and have moved to decriminalize drug use in many states, pregnant people are still subject to punitive responses for actions that would not be considered illegal, but for their pregnancy. So the criminalization of prenatal substance use, it identifies the fetus as a victim, advancing the personhood agenda, and then opening the door for further pregnancy criminalization. So after all that being said, I'm happy to turn it over to our panelists. Purvaja, I'd love to start with you. Thank you so much for joining us today and for your instrumental work on this report. Before we dig into these wide-ranging implications, can you share the findings or other key takeaways that surprised you during the research process?
Yeah, sure. Thanks, Khiara, for talking through a lot of the results. And thank you everyone for joining. So what Khiara did a really great job doing a really quick overview, but so what stood out to me, everything. But one thing that we haven't touched on yet is the hospital to prison pipeline. So our documentation work makes really clear that there was a hospital to prison pipeline. Among the cases where we could identify the mechanism through which a pregnant person comes under state surveillance, 1 in 3 pregnancy criminalization cases were first instigated by a medical professional. 2 in 5 involved a family regulation worker, also known as a child welfare worker. So basically, that is to say that disclosure of information that led to the eventual arrest or detention of a pregnant person was made by a healthcare professional, be that a doctor, a nurse, midwives, hospital workers, social workers, hospital administrators, drug treatment counselors, to name a few. So the thing that stood out to me was this pipelines: hospital worker to police, hospital worker, family regulation to police. And this pipeline, combined with the fact that our data shows that this is very much a story of a prosecution of poverty, shows that pregnant people's needs for medical care and a social safety net, financial or otherwise, is turned against them towards criminalization. This isn't simply a social service, the prison pipeline, but it's turning a human need to a human rights violation pipeline. And again, situating it, what surprises me is, well, not surprises me, but makes me sad, is how this neatly fits into the history of criminalization more broadly in this country. This country has a long history of addressing social problems with carceral solutions. The state uses its failure to meet social needs to justify its expansion of the criminal system. It uses its failure to exert punitive control. And so we see that with these cases, right? Anti-abortion activists, advocates, state actors justify pregnancy criminalization, essentially this funneling of poorer communities into carceral surveillance systems, because apparently they care. And when we care, we want you to get access to care. And the best way to do that is through prisons, which all of us here know is wrong, because nothing about criminalization is about care. It's all about control. And to say the very least, reports show that prisons have really substandard healthcare, let alone pregnancy care. Often their pregnancy care can be deeply dangerous. So I'll wrap up, but what stood out to me essentially is this prosecution of poverty, how having a lower socioeconomic status somehow means you deserve a lower standard of medical care or counseling, or you deserve a lower level of bodily autonomy, or a lower freedom to exist in your community without surveillance. When I joined this documentation work 3 years ago, I was shocked to learn there was even 1 case, let alone 400 pregnancy criminalization cases in the old report, let alone 1,400 in this current report. What stood out to me through this writing is how wrong this is and how pregnancy criminalization is rising.
Yeah, thank you so much for raising those points, Purvaja. I want to turn it to you, Professor Bridges, because Your research in your first book, in the public hospital setting, notes that race and class have material consequences for those seeking prenatal care. Can you discuss the process by which providers and hospital staff produce this disparity in care?
Sure. Thank you for the question. So my first book is called Reproducing Race, and it is an ethnography of obstetrics clinic in a public hospital in New York City. I call the public hospital Alpha, but if you've lived in New York for, I don't know, 2 minutes, you can identify this hospital. But what I was interested in doing in the book was kind of tracking how racial discourses and discourses around class and discourses around gender, as well as law and medicine, sort of intersect to produce particular experiences of pregnancy. And I was drawn to the project because, as a law student, I was struck by how pregnancy was spoken about in Supreme Court cases, particularly, and from Griswold versus Connecticut to even Eisenstadt and Roe. Pregnancy was sort of spoken about as like this magnificent thing that is a good for the person who is pregnant, and also good for the family and society and the nation more generally, even when it comes at a bad time, right? That's what's sort of the way Roe and Planned Parenthood versus Casey spoke about it. But it was sort of conceptualized as like fundamentally a good thing. But then looking at how pregnancy was conceptualized when it happened to people of color, or happened to low-income people, and undocumented people, or people with disabilities, that same sort of conceptualization of pregnancy as a good thing just wasn't found. And so I wanted to sort of track that, in the material space of an obstetrics clinic of a public hospital. And that's precisely what I found. The book kind of offers that public hospitals are racialized, right? They're racialized at first as like poor people's hospital. Like if you are not poor, you do your best to avoid ending up in a public hospital. And that was true certainly in New York City. It's true. I live in, the Bay Area now. It's sort of something that is not at all unique to the place where I did the research. And so public hospitals are poor people's hospitals. And then because of the way that, race unprivileged follows class unprivileged in the US, it tends to be places where people of color are disproportionately found. And we add the fact that these are poor people / people of color's hospital to the fact that it is, and in the US, our public healthcare system is underfunded. It is understaffed and it is overburdened. And so the experience of receiving care in a public hospital is one where your time is devalued. Your appointment might be at 2. You're lucky if you get out at 5. The experience of healthcare that more affluent people kind of expect is just something that is not afforded to low income folks. In my book, I was really interested in how Medicaid programs structured the dispensation of healthcare. And what I observed, at Medicaid, in order for the hospital and the providers to be reimbursed through the Medicaid program, they had to provide sort of a program of care. And this program of care included, consultations with social workers and nutritionists and financial counselors and health educators. And the result was this experience of like carcerality. A lot of times, because it's important to note that the social workers who worked in the hospital, they were mandated reporters. And so you don't have the fiduciary relationship where you can confess, the things that are occurring in your life to a person who is like charged by law to keep those, that information as your agent. Instead, the loyalties were to the state. And so there was this experience of these roles, social worker, health educator, sort of being presented as if they were for the benefit of the patient, when in fact their primary loyalty was to the state and to the report to the state. the things that might raise the state's interest in terms of child abuse and neglect and things. So I can go on, but I want to mention one last thing. Wasn't present in the New York City hospital that I worked in, but certainly present in other jurisdictions across the nation, is that in public hospitals, more so than any private hospital, I haven't even heard of a private hospital, public hospitals will have a policy of drug testing all of the people who receive their care there. Drug testing the fetuses, the babies, the pregnant person at some point during the pregnancy, or shortly after delivery. And when you have a policy of drug testing as like sort of a blanket policy, you're going to catch folks who have used substances at some point during their pregnancy. The thing is, for more affluent folks who labor and deliver and receive their prenatal care from private doctors or in private hospitals, you just won't find sort of blanket policies of drug screening. And so you're not going to catch them. And so we produce what we expect. We produce the numbers that say that is low income people who are using substances while pregnant, and affluent people who are not using substances at all. And so it's sort of a self-fulfilling prophecy. And then we ought not to wonder or be surprised at all that the statistics that you showed on the first slide exist, that of 85% of these prosecutions involve people who are indigent enough to need to turn to public defense. So it's not because people of low income people use substances at higher rates. It's rather because we're more apt to find and detect their substance use rather than in their affluent counterparts.
Absolutely. Thank you so much for that insight. Dr. Moayedi, as an OBGYN, can you provide a little more insight on how healthcare providers intentionally or even unintentionally contribute to the criminalization or surveillance of pregnancy, whether that be at the hands of the police or the family regulation workers?
Yeah, thank you so much. And, I think to Dr. Bridges' point, it's even sometimes even more nefarious than a blanket policy, that it might not even be a blanket policy, that it is a general culture of surveillance within the hospital, but not actually a written policy of who gets drug tested and who doesn't. And I would say that how healthcare providers participate or perpetuate this is kind of in two main buckets. One of them is unintentionally, and one of them is very much intentionally. And so in the unintentional piece, it is potentially well-meaning physicians, nurses, and social workers who really view the family surveillance system as a tool for good. Maybe don't have a deep understanding of what happens in the family surveillance system, think that this is an opportunity to get people help. And so really they are plugging people into this pipeline because they think they are doing something good and are acting in a benevolent way in service of their patients or the people they are serving. Now, in a state like Texas, we have a completely broken family surveillance system. We have the highest family separation cases in the country once people are reported to CPS. Our foster care system is documented as abusive and well documented in trafficking children and exposing them to sexual violence. And so that piece, though, gets really left out in our training, right? That certainly physicians, nurses, social workers wouldn't be connecting children into these sorts of systems if they knew the reality of what was happening. But our education and our training around these systems is not a critical one. We don't critically analyze how these systems actually function and who they function for. We really present them as neutral, that this is how we get people help. And so in those settings, I have come across and talked to colleagues that say, we should drug test so we can get them help. We should drug test to make sure they're getting the right support. And sometimes completely medically off base. We should drug test so we know which medicines to give. Well, there's not, for the most part, not a medical basis to that. We should drug test so I know how to treat the infant. Well, you can actually just treat, and there are protocols for just observing and treating the infant. We don't have to drug test for that. And then I would say the other bucket is really very intentional and nefarious. I've had physicians tell me, well, we need to drug test so we can build a case against her. So very much intentionally wanting to build, whatever that means, build a case against someone. And so really viewing the pregnant person as in opposition to the baby, that they are the enemy of the baby. And you know, to some extent, I can understand when someone works solely in a certain setting where they see a lot of abuse, they see a lot of harm to children, that this can skew the way that you view the world. But certainly approaching the care of parents and their children as being opposed to each other, as not wanting to support keeping people together, is highly problematic and is going to result in continued abuses and harms to families. So how do healthcare providers participate in this? I think there is this direct, really like wanting to get people. I mean, there are countless stories of physicians or nurses that will bring the police in. I have consulted on cases where someone's emergency has literally just finished, and then the doctor escorts the police officer in and helps them really in their information gathering. And then that can happen in the charting that people do too, really adding extraneous information into a chart that is then later used in multiple ways. Part of that we don't realize. I think a lot of physicians, we're taught kind of this way to chart, that we should include all of this information, and that we don't, again, critically analyze why. The importance is that we need to put in information that will help us clinically with the patient, and we need to always have a heightened awareness of how this can be used to harm people too. So there's this intentional piece, but I think that the other way that we participate in this harm and criminalization is through intentional ignorance, through not actually incorporating a critical racial analysis and a critical social analysis into our medical education, by not naming what is unsaid, the racial piece, the poverty piece, and by acting like medicine is race neutral, that medicine is unbiased, or that bias is actually individual only and not baked into our systems, that is not actually the structure of the healthcare we provide. And so when we approach issues like racism in medicine, it is about a racist person potentially, and not actually how our entire policy supports white supremacy, how our entire policy supports criminalization. And so I think there are multiple levels as far as how healthcare providers continue to perpetuate this harm and really continue to ignore the structures that perpetuate the harm.
Absolutely. Thank you so much for that. That was a fantastic overview and a wonderful perspective. We rarely get to speak with healthcare professionals about how this actually operates. Kassandra, all that being said, I want to turn to discuss the behavior most often criminalized during pregnancy, which is substance use. On the ground, organizations like Drug Policy Alliance are fighting towards decriminalization and justice for those harmed by the drug war. How do you see pregnancy criminalization as an extension of the drug war's racist origins?
Thank you so much for having me. I'm incredibly grateful to be here and on this panel with you all. You know, I would start by pushing back on the idea that pregnancy criminalization is an extension of the war on drugs. I think it's important to name that so much of the war on drugs has been waged with the idea and the intention and the propaganda around pushing the fact that we needed to do this extremely violent war to protect children and to protect people, the next generation, right? And so much of the propaganda around the war on drugs is steeped in deeply controlling and sexist and homophobic rhetoric and actions. I also think it's really important to name that, I know the conversation is like, the research has been focused on like what has been the risk to pregnant people after Dobbs and post Dobbs, right? And what I would offer is that Dobbs never really offered much protection to poor people and folks of color, and that while it was important, it also lulled a lot of people into this false sense of security about the health and well-being of people who had the capacity for pregnancy. And I'd also name, as someone who was trained as a social worker, social workers are essentially human resources, where we're teaching people in their jobs that human resources actually works for the company. In a medical and hospital setting, social workers work for the hospital, and they work for the schools, and they work for the agencies. And while there is a lull or this perspective that they are are there for the person that in front of them, they're there to protect the interests of the entity that they are employed by. So what I would name is that the drug war has a particular set of people that they target explicitly. Poor people, folks that are not white, and people who have the capacity for pregnancy. And I think it is someone's ability to be pregnant that increases the level of surveillance that the state can have on them. And so they don't need the excuse of drugs as a reason to violate someone's privacy. They, as the report shows, drugs is the excuse that they use, but it is the pregnancy that brings them to the yard in the first place, right? And so both those things are really important to contend with, because it's not as if the surveillance is there because the person is using drugs. The surveillance is there because the person is pregnant. And I think that is a critical lying theme that we have to be really cognizant of. And I start there because I think it's important for people that do drug policy work to see people's capacity for pregnancy to be a mitigating factor to criminalization and surveillance. Because often we've gotten to a place where now we are more readily able to admit that someone's class or someone's neighborhood or someone's race will make them more likely to be engaged by the drug war. But I don't think that we have built the infrastructure or the knowledge base that pregnancy is also a mitigating factor not a mitigating factor, a factor in someone being engaged by the war on drugs, because someone who has the capacity for pregnancy now has a way lower threshold for society's appetite for now people in society feel like they are owed the right to surveil this group of people because of this idea of like saving the generation, saving children, fetal personhood. But because someone becomes pregnant, they are no longer themselves. They are no longer have rights to their bodies. And I think that this is an underlying organizing principle of drug policy reform, is fighting for personal autonomy. Being a person who's Black in America, I'm very clear that my personal autonomy is limited. But I also know, being a Black person who has the capacity to be pregnant or could be pregnant, that once I am pregnant, that level of autonomy even gets cut down even more. And so I think on the ground organizations like Drug Policy Alliance or National Harm Reduction Coalition or the National Survivors Union, I think a lot of times we're really trying to figure out how is it that we're learning and building our campaigns to platform and actually get us to a place where we're recognizing the capacity for pregnancy as one of the driving factors of why someone is targeted. And I think this report really lays that out, because it hits all the reasons why we know other groups of communities are targeted for the drug war. And I think I would say that in our movement space, we don't necessarily, we hide that population because we know that it's not a politically viable, or it's not yet currently politically viable to lead with or to fight for the rights of pregnant people who are using drugs. And I think that is something that we're learning. I mean, if you even look at, it's not just the criminalization associated with pregnancy, it's also the kinds of treatment options that pregnant people have. Like, are they even welcome in treatment facilities? Are they welcome in syringe exchanges? Are they welcome in overdose prevention spaces? Are we talking about, as we're moving towards decriminalization, we're not leading with pregnant people in our ads, like, you shouldn't arrest these people, because some people in our movement, I don't know if they think they should be arrested, but they're a little nervous to say that they should not be arrested. And I would also say that as we move the conversation forward, even when pregnant people are taking medications to deal with, let's say, an opioid addiction like methadone, we see that when they're in family court and they're getting drug tested and they admit to methadone, which is the gold standard of treatment for opioids, they're still criminalized. They still lose custody of their kids. And so there's this idea that pregnant people should have this bubble around them and not be engaged with the world, and are not, that makes it difficult for us to actually protect their rights and autonomy and their safety and well-being. And it is, in fact, that kind of criminalization and stigmatization and lack of information that makes it more dangerous for someone who has a capacity for birth, right? Because if you look at different studies, you'll see that in the midst of the overdose crisis, the group of people that is having some of the highest rates are pregnant people. And so it's coming out on both sides, right? It's the criminalization, but it's also, and you do the criminalization because you want to say that you want to keep them safe. But on the other side of it, they're dying of overdose because of the criminalization, because of the lack of access to supports, and that those conversations are intertwined, and that we're losing on all sides. Yeah. So it's not necessarily, so I wouldn't characterize it as an extension of the drug war. I would characterize it as the drug war.
And I think Kassandra's point is so important, that this is not like these universal policies, like Dr. Bridges talked about on labor and delivery, aren't across the whole hospital. So it really is not about helping people in our community with substance use at all. It is really about identifying pregnant people and separating them from their children. And these policies, right, they're not coupled with true drug treatment. And if we think about just how do we get people who need help with any form of substance use help? Well, the first step is that they have to want help. And so actually, we don't need to test anyone. Someone just needs to say, I want help. And that's how we connect them with help. But when we approach, we're helping someone with a test that then has a punitive consequence at the end, then we have to be real. We're not actually trying to help people at all. We're trying to identify people to separate from children.
And I just want to name here, I think the thing that really crystallized it for me was when the Dobbs decision came out. In the dissent, in the opinion that Supreme Court Justice Thomas put out, he says, if we let them do this pregnancy thing, if we let them do this abortion thing, then they're gonna say they can use drugs. Then they said they can use sex work. And so this is why I keep coming back to, like, this is the war, right? Like, the war is on, and the front line is pregnant people, right? Like, it's like people, like, these are the people that we are all acculturated to think that they have less rights. Yeah. And so if we're like centering that of pregnant people and our advocacy for that of civil liberties, no one has, there are a lot of people, not trying to play oppression Olympics. And there are very few other populations that have less rights than someone who is pregnant. Right? And you can add on all the other stuff, but like once someone's pregnant, it's like game on. Like, we can do any test and we can say it's for whatever.
Yeah. I'll just say, since getting involved in this work, my idea of pregnancy and this idea that it will be this like wonderful and joyous time in my life has completely transformed. I am on like red alert. But I want to be mindful of time. I maybe we can move into the Q&A, and maybe some of the questions that folks have will mirror some of the questions and talking points that I wanted to discuss. I'm gonna look through some of these really quickly and then point out a few that we can discuss.
Pikayo, while you look, I know it's really hard to read and talk at the same time. So while you look, I'll just add, I just want to build, Kassandra, what you were saying. I was taking notes. I'm taking notes. I'm learning over here. I love this. But I just wanted to just like amplify something that you said, and that is the substance use is just an excuse for the surveillance, right? Because I was thinking about all the cases of pregnancy criminalization that don't involve substance use. I mean, I can tell you the audience, and I'm sure the audience might be familiar with some of these cases of people facing murder and manslaughter charges for things like falling down steps. For things like getting into a fight. There was a case out of Alabama where a pregnant person got into a fight. The woman that she was fighting pulled out a gun and shot the pregnant woman in the abdomen. The woman lost her baby. She suffered a miscarriage, and she faced manslaughter charges because the prosecutor said, you as a pregnant person should have avoided the fight, right? So we are penalizing pregnant people for behaving in non-normative ways, and substance use during pregnancy is just one of myriad non-normative ways that justify, the carceral state getting involved. And the other thing that I wanted to mention, Pikayo, while you look through those questions, is that pregnant people lose their rights, right? They lose their privacy, they lose their ability to make decisions, they lose everything because they're pregnant. And a lot of times folks will justify the loss of autonomy and privacy because we just care about your fetus. We want what's best for the baby and for the future generation. But if we really cared, we would not be responding with carceral systems. We would not be responding by sending people to jails and prisons, which lack healthcare, which are dirty, which are violent, right? Which, is a recipe for terrible pregnancy outcomes. Also, if we really cared about fetuses and babies, we would make sure that pregnant folks had access to food, that they had access to shelter, that they had access to clothing, that they were free from intimate partner violence. Like we would make sure they had access to water that doesn't have lead in it and air that's not polluted. But we don't do that, right? We don't engage in the structural interventions that would ensure that everybody, including pregnant folks, have access to, again, basic necessities, healthy environments. Instead, we respond to criminalizing pregnant people when they engage in behavior that might risk a negative pregnancy outcome. So I just wanted to note the incredible irony and inconsistency of this claim that we are interested in protecting fetuses and babies by throwing them in dirty prisons and jails.
Absolutely. Purvaja, I'm gonna direct this question to you because I think it's something that was very important to highlight once this report was released. Someone asked, so how do we as a community get involved and prevent this from occurring to those targeted in this way?
Yeah, great question. That is the big question. I'll give like a quick answer and then I'll get into like a longer answer. The quick answer, read the report. The quick answer is we also have a second report that came out on confronting pregnancy criminalization that has like specific steps for different actors. But something that I like thinking about, or I'm gonna take this question and then run with it because this is my spiel whenever I think about organizing. So like as all the co-panelists have talked about, pregnancy criminalization, super scary, because period, it's scary, but like it's so interconnected with all these different systems. And so we're also seeing all these different sites for all these systems to increase, and all these actors are part of this like horrible network of pregnancy criminalization. But my spiel is that hope is a practice. And then as we see these sites for pregnancy criminalization increasing, also the sites for potential allyship and collaboration also increase. So in answering your question, what can we do? Those of you who are working on reproductive rights, continue what you're doing, read the report, hope you use that report to inform your work. But you don't have to be directly working in reproductive rights to confront and stop pregnancy criminalization. Given how pregnancy criminalization exists in so many settings, our movement has space and needs people who are hospital workers, harm reduction organizations, drug policy groups, like Kassandra saying. The drug war is the war on pregnant people as well. We need gender justice groups, racial justice groups, public health researchers, all working in their spaces to remove carceral surveillance from care systems. That can be through raising awareness, mobilizing people's movements, but also like through policy change at the various levels, federal, state, to like your workplace, to try and like fight that sort of Dr. Moayedi talks about the culture of like wanting to incarcerate people. And so I also think, so we all have a space. And like, when I think about pregnancy criminalization and inclusion into our studies, you got arrested, right? However, there's so much harm that happens before an arrest, right? You could face a non-consensual drug test. Family regulation workers come to your house and surveil you and your family. There are interrogations. You are separated from your newborn. You're separated from your existing children. They're placed in foster care. You lose your parental rights. And you could also be detained in a hospital, to name a few deprivations. So I think advocates in our fields, we can all work in many ways to interrupt these pre-arrest deprivations, and in doing so, like break the pathway to an eventual pregnancy arrest. But yeah, read the report.
Can I add something? Yeah. I would also say, you know, there are groups around the country that are building campaigns around informed consent, getting parents that are organizing, trying to change hospital policies. There's also a national movement of folks that are saying, you know, support, don't punish, which is about changing the practice of mandated reporting. So there's so many folks on here who are probably social workers, really taking this information and pushing your local NASWs, the national NASW, and get social workers to really push back on the practice of mandated reporting, and also doing your own versions of direct actions, right? Like, don't report it. Right? Like, figure out, like, the idea that someone has to be engaged in a carceral intervention in order to get help is a false choice. Just help the patient. Just help the person in front of you. Just give them access to the resources without hitting the criminalization button. Figure out what you can be doing. And if you can't do stuff, support organizations like Plan or Movement for Family Power that are running these campaigns. Some people don't have the time, but they have resources. There are people that are doing this on the ground, organizing, that are not large national organizations, that are groups of pregnant people, that are groups of parents who are doing this organizing on the ground, and they deserve our unyielding support. And so some of the campaigns that you can Google and find more of are Informed Consent, Support, Don't Punish, which is about ending mandating reporting, and also just really pushing on the different hospitals that we're a part of and seeing how we can change administrative policies so that people don't have to deal with this.
Yeah.
Can I add one thing really quickly? I also think in terms of like a social thing that we can do is state actors manipulate the idea that a pregnant person is acting in the worst interest of their fetus and creates this adversarial relationship between the pregnant person and the fetus. And that is wrong. And it obscures the real adversarial relationship, which is pregnant person and their body which may include the fetus, the baby, and the state failing in so many ways. So I think like being more aware of that when like talking about like just like narrative change is also really important.
Absolutely. Yeah. I mean, something very powerful that I always remember is that a drug test is not a parenting test, you know, but I want to attend to some questions that we have. Are you able to comment, I believe this is to Dr. Bridges, are you able to comment on the fact that more white individuals are criminalized compared to Black, Brown, I assume Indigenous individuals, even though we know the carceral system disproportionately impacts those communities more than white individuals?
Yeah, thank you for that question and for giving me an opportunity to begin to address it. So the law review article that was mentioned at the top of the webinar, what is it called? White privilege and the criminalization of opioid use during pregnancy. That's the article in which I sort of tried to figure out, right, how to make sense of the fact that white people were proliferating amongst those who have been prosecuted for substance use during pregnancy. And I'll begin my answer just by noting, I feel very strongly that anti-Blackness is bad for white people too. We know anti-Blackness is bad for Black people, right? But I think it's important for us to understand that anti-Blackness is bad for white people, anti-Latinx, anti-Indigenous, right? All of that is bad for white people as well. Not playing a professional Olympics at all, but it's bad too. And so we ought to understand this moment as not to distinguish it or understand it in isolation from what came before, which was the crack cocaine scare. It was during the crack cocaine scare of the 1980s and 1990s that prosecutors started using creative interpretations of the criminal law in order to criminalize people who had negative outcomes or had the risk of having negative pregnancy outcomes because they ingested crack cocaine during their pregnancies. Now, we all know, hopefully on this call, that the crack cocaine scare was racialized as Black. It disproportionately affected Black communities. So those who were swept up within the carceral systems during that time were overwhelmingly Black people. Ferguson versus City of Charleston, the case in which the Supreme Court said that it was a violation of Fourth Amendment rights to essentially that program ran afoul of Fourth Amendment rights. The folks who were criminalized under that program, all of them were Black people, with the exception of one white woman, and the nurse had made a note in her health records that said lived with a Negro. So these were all people who were either Black or whose whiteness had been sullied by their association with Blackness. So we created this racist precedent, right, for dealing with substance use during pregnancy during the crack cocaine scare. We have path dependence as a nation. We now have a racist precedent for dealing with the opioid epidemic and the methamphetamine scare, right? Our path dependence means that we are incapable of imagining different solutions to a phenomenon. And the phenomenon is substance use during pregnancy. And so I understand white people as sort of reaping the bitter seeds that were sown for people of color just 40 years ago. And this is an example, again, of how anti-Blackness is bad for white folks. We've created these systems. Our imaginations are cabined. We know what to do, right, with substance use during pregnancy because we responded in a racist way just 40 years ago. And that's how I understand white people being swept up into these systems that were designed and practiced upon Black people just, again, half a decade ago.
Yeah, I want to be mindful of time. I have a question here that I think would be really great to answer. And I also want to note that folks that have joined this panel, there's a survey that's been released. Please answer it, or please reply and supply answers, because that'll help us inform future advocacy efforts, trainings, and whatnot. Someone asked, How can residents and doctors be trained to deal with police? My husband is an ER doc in California and received zero formal training in his residency on how to work with the police. Many of his co-residents and colleagues thought that they are legally required to comply with the police requests and allow them in the exam room, look at charts, etc.
So this is a great question. I think there are a lot of other kind of sub questions that fit into this that I'll try and touch on. As far as I'm aware, there is not really a formalized training for how physicians should deal with police. And really my education on how to respond to the police, but also how to respond to immigration and ICE when they present into the hospital is really from my work in activism and organizing. And so I really think physicians, healthcare workers need to be more engaged with community organizers within their communities, both to understand what are the laws in your state or in your community around engagement with the police and what are the tactics that have been successful in your community in resisting cooperation with the police. But and that, it is at the individual level, and maybe it is more at the institutional level too. Everyone has a different level of power within, for example, a hospital or a clinic system. And none of these things happen overnight. There's a lot of questions about like, how do I change what our hospital is doing? They're doing this awful thing. These things take an incredible amount of time. And really it is super boring to start with. You need to join that super boring committee in the hospital and be on that committee and be in those meetings and see who is making the rules, understand how policies are made in your hospital, and then understand how they are changed in your hospital. Be the person that asks really annoying questions. It doesn't have to be a fight at every meeting, but just a pointed question over and over again, whether it is about like, well, why do we do it like that? Interesting. Well, what is the race of the people that we report? What is the racial disparity? So start asking these probing questions. And there's a reason for that. One, to start planting that seed in people's minds, but also to start drawing out your allies, because it cannot be just one person that can change a system. And I think that it really is important and brings to another question about like pediatricians being very concerned. And I see this a lot, pediatricians saying that we need to drug test because what if we send the baby home and something awful happens? Well, we really need to take a step back and understand that like we aren't saviors. We aren't saviors of the world. We can barely save people's, I mean, we do, but like, right, our ability to change and save the world on an individual basis is actually really, I think, conflated in how we approach medical care. And so it is our responsibility to serve people through the education and training we have, but it is outside of our capacity and our role to like save all the children in the world, save all the children in the community. And so it's not incumbent on us to make sure every single kid is in 100% safe home. Yes, it is our moral obligation to make sure that our communities are safe, but like there's nothing in our medical training that prepares us for that sort of systems work. So I think it's almost a false belief that we have that maybe we can drug test our way into community safety. It's just absolutely false.
Yeah.
And then I think like, what are some programs or other ways? There's a really a new educational program through Innovating Education. It's called Doing Right at Birth, and it's a self-paced online course for healthcare professionals to learn about child welfare reporting. And I think, an important thing to bring up is, yes, many of us are mandatory reporters, but there aren't many states that have mandatory reporting laws around drug use and pregnancy. So like how we use mandatory reporting is actually often ill-informed, and we need to interrogate those systems.
Yeah, I know we are at time, and I want to give space for Lourdes to offer her closing remarks. Lourdes, take it away.
Well, first, I just want to thank you all. This has been such a robust conversation. I know it only scratches the surface. I certainly learned a lot, and I hope that you all did too.
I want to highlight that we'll be tracking future prosecutions through our newly launched Pregnancy Prosecutions Tracking Project. It's a collaboration with the University of Tennessee, University of Texas, Austin, and University of South Carolina Schools of Law, which will let us monitor and analyze pregnancy criminalization on a more ongoing basis. Please help us track these cases and trends, and you'll find a link in the chat. And this report and panel is a call to action. We need to dismantle the harmful and punitive systems and practices that criminalize people based on gender, race, and class. And we invite you and others to read the report and to join us in the fight. And just thank you.
Thank you, everyone.
Thank you.